Is now starting. All attendees are in listen-only mode.
All right, hello and welcome. Hi everyone, I'm so glad that you could join us today. My name is Colleen Marshall. I'm a marriage family therapist by training and also a member of MINT, and have been training in motivational interviewing and part of the MINT network for over 15 years now. And I'm happy to join you guys today and to talk a little bit about how MI might be able to help us with vaccination conversations. We're also going to talk about the FRAME network, or the FRAME framework, which is another recommended model. There's two evidence-based models that are recommended for vaccination conversations. One of them is FRAMES and one of them is MI. And so today we're going to do a quick overview of both. I'll also do a small demonstration of both so you can just hear what it might sound like and how they're slightly different. And Jamie, thank you so much for supporting me in all of this and for hosting us and managing the slides. If you have questions, feel free to put them in the question section on GoToWebinar, and I'll try to make time at the end for that as well. All right, let's go to our first slide.
All right.
Maybe make it just a little bigger if you can, Jamie. A little smaller. All right, we'll go to the outline. So just perfect, that's perfect. So you can just scroll up a little bit. So we're going to go to the outline slide, which is right below. Jamie, if you can scroll up. Great. So we're going to start with talking about frames and what that model is, and then I'll show you a little brief demonstration of that. And then we'll talk about the basics of motivational interviewing, just to set the stage. This isn't a full in-depth training on motivational interviewing. It's just to give you a high level of what MI is about. And then specifically the EPE part of MI that we talk about how to provide information in an MI consistent way. And then we'll have demonstration and Q&A at the end. Great, go to the next slide. So frames, so what is frames? Why do we do it? You can go ahead, Jamie. So frames, the model stands for feedback, responsibility, advice, menu, empathy, and self-efficacy. And the concept is what we're trying to do in both of these models is really empower, in this case, since we're talking about HPV vaccinations, empowering the parent, but if we were talking about other vaccinations, it would be empowering the patient to really have autonomy and choice and control over their life, and for us to come as providers with the expertise that we have and also some empathy and understanding of what they're trying to accomplish and what their goals are for their child and for care. So the feedback part is the action that we're trying to deliver is being really clear about the explanation of the health risk. So we want to make sure we're providing feedback of the personal risk so that they can make an informed choice. We don't want to be providing that information as persuasive or trying to tell someone what to do or pressure someone into what to do. Instead, the real purpose is to provide factual, objective information that's based on the risk, and to use this opportunity to have a conversation about risk reduction counseling, so that the client, again, or the patient or the patient's parent in this case, can make an informed choice. We also want to highlight the idea of responsibility of the patient. So this is supporting autonomy, choice, and control. And what we know from the field of psychology is that the more that we allow someone to make choices in their life rather than pressuring them to make choices in their life, they're more likely to make choices that are on the continuum of being healthy and good for them. So we want to support autonomy. You might say something like, you have the ultimate control here over whatever you choose. Vaccination decisions are up to you as a parent. I would like to just provide you information, but it's 100% up to you. This is, squarely in your lap to decide what's right for your child. However you want to say it, there isn't a perfect script, but the concept is we want to emphasize the responsibility is up to the parent in this case, or the patient in other situations, to choose what's right for them in this, based on what we're talking about. And we want to emphasize the decision comes from them, not from us. So even though we might have a medically informed decision and we might have a strong opinion, it is not ours to make the choice. We also, though, want to provide advice in the FRAMES network. We want to make sure that we are providing our medical recommendation. That is why the client's coming to us. They are paying to have us provide care for them because of our medical expertise and training. And so we do want to authoritatively, clearly state what we think is the right choice here from a medical perspective, without it feeling like pressure or telling someone what they have to do or need to do. And then the last piece is this menu of strategies, which is we really want to think about all the different options that could meet this same situation. So we want to emphasize that patient choice and responsibility for the change process, and the patient selects the strategy that works best for them. And we want to provide as many options that are medically appropriate. So it might include things like psychotherapies that could help, avoiding high-risk situations, encouraging alternative behaviors, changing environmental antecedents. There's lots of things that could be menu of options we could provide here. So if there are things that we can provide, we definitely want to include that in the FRAMES network, or FRAMES framework, excuse me. And we can go to the next slide. And so what that might sound like is, from the action perspective, we might say to a parent, acknowledging first the emotion and I'm forgetting that this is the second piece of the FRAMES. So the other piece of FRAMES is the empathetic style, which also you're going to see in the MI piece, which is we really want to provide emotional support, but even more importantly, understanding of the emotion and the meaning behind what the parent is sharing with us, and in other situations, what our clients or patients are sharing with us. So we want to acknowledge the emotion in this decision, acknowledge what it means for the family. And it might sound something like, deciding what is best for your child is hard. This is a difficult decision. You've been thinking about a lot. It's been weighing on you. There's lots of ways you could be reflecting back what you believe to be the emotion and the meaning behind the conversation. And then lastly, we want to promote self-efficacy. So self-efficacy is that big word around building confidence, having someone believe they can do something. So the action is we want to really affirm or acknowledge confidence and strength when we see it. So your health and family seems very important to you and you're doing what you think is best. Again, we're building that confidence and that belief that the family or the parent in the situation really can do what is best for themselves and their child. And the purpose really is to communicate confidence in the patient's ability to change and remind the patient of her personal reasons for change. So why this is important to them, not why we think it's important. So here's just an example of how it might sound. It might sound like, would it be okay if we talked about HPV vaccinations and what HPV vaccinations can prevent? And then emphasizing responsibility of the patient. You're the only one that can decide whether to get vaccinations. Just so you're aware that your child does get your HPV vaccination, the CDC does recommend that all 11 to 12-year-olds get the HPV vaccination. And then we can provide strategies or menu of strategies. You could start now, ages 9 to 12, which is what the CD recommends, 11 to 12. You could start in 6 months. You could certainly do it at next year's physical. It is a 2-dose regimen, so you want to do 1 dose before the 15th birthday, and then three doses after the 5th. If you only want 2 doses, it's before the 15th birthday, and 3 doses after the 15th birthday. So giving them all those options, they can choose. And then we want to make sure we're regularly checking in with how they're feeling. So we might say something like, deciding what is best for your family is hard. And then again, promoting that self-efficacy. Your health and family seems very important to you. And you're doing what you think is best. So just a quick example of how that might sound. But let me show you how it sounds in practice. I'm going to play a little demo I did, the recording for you. So thank you so much for coming in with your daughter today. I was hoping, would it be okay if we talked for a few minutes about the HPV vaccination?
Yeah, I told her that we weren't going to get any shots today, so I don't think we'll be doing that today.
Yeah, and you are definitely the only one that can decide what's right for your daughter and what you think is best for her. But what I was hoping is, if it's okay with you, I'd like to just tell you a little bit about what we recommend around HPV, and then you absolutely can decide what's right for you and your daughter.
All right.
Okay, great. So just so you're aware, the CDC actually recommends that children at the age of 11 and 12 get the HPV vaccination, and your daughter is 12 now. So it's recommended that she actually get it. She get it now so that she doesn't run the risk of actually getting HPV later in life. So I wonder what you think about that.
Well, I guess I'm just a little confused because she's 12. She's pretty young. Isn't HPV for sexually transmitted diseases?
Yeah, it can be, but usually why we do it is before kids are sexually active. And so that 11 to 12 is really where the CDC is best. And there's many options we can talk about if that feels right to you guys. But it is my recommendation that she does get an HPV vaccination. But of course it is you're the parent, you get to decide what's right for your child. So what do you think about that?
Well, I suppose if you think that I should get this for her, that's the best thing to do, then I would agree.
Yeah, I totally get it. And I also hear that you don't want to do it necessarily today because you told her no shots today. But there are some options we can start doing in 6 months from now. You could come in, we can make an appointment. We could do it at her next year physical, but it is a 2-dose process. And so we would just want to make sure you get her second dose before her 15th birthday. And then she'll get 3 doses after her 15th birthday. So what do you think about those choices?
Okay, that sounds good. I guess we could come back in 6 months later and get the first dose and then go ahead and make sure we get both doses before her 15th birthday. Okay.
Yeah, I mean, it's definitely what I would recommend. And it sounds like what you're really trying to do is just make sure that you take care of your daughter, and your family's health is really important to you. So that seems like that's the choice that feels right to you right now.
Yeah, that's what's important to me right now.
Okay, great.
All right, great. I should have flagged, by the way, that I'm not an expert on HPV. So if there's pieces in my role play that you would have said something different or provided more information, please do that. You guys are absolutely the experts with HPV and the things you would want your clients to know about that. But hopefully you could see kind of how the frame model could sound. All right, so let's move on to motivational interviewing. So you can go to the next slide. So what is motivational interviewing? It's really on the high level is around why people change. And so I want you to think about it for a moment for yourself about something that maybe you've been thinking about changing, or you should have done. Maybe it's you're not getting enough sleep. Maybe you're not exercising as much as you're supposed to, or eating as many vegetables, or maybe you want to lose weight. But I'm going to use the flossing our teeth as an example because oftentimes we don't floss our teeth twice a day like our dentist tells us to. So just as an example, I want you to think about something that you have not changed and ask yourself these questions. And I'm going to use the flossing our teeth as my example. I don't floss my teeth twice a day. So, and for you, whatever that behavior is it because you don't have the information? Do you not know, like you've not met a dental hygienist? Have they not told you that we're supposed to be flossing our teeth? Is it just that you need information to change? And my guess is if I saw you all, you'd be shaking your head. No, it's not really about that. So then we go to, well, is it a skill? Is it you don't know how? Is someone not taught you how to floss your teeth? Is it, now they even have those little pick things. You don't even have to learn how to wrap it around your finger. Is it really skill? Like if you learned how to floss your teeth, would you do it twice a day? My guess also is for most of you, you're shaking your head. No, it's not really that. So then we go to, well, is it something wrong with you? Are you just stubborn? Is it, you just, are trying to hurt yourself in some way, or you want your teeth to get bad? Is there something with your personality that makes this hard? And my guess, again, we're shaking your head, maybe I'm a little stubborn, but no, I don't really think that's it. So is it something else? Is there something, there's another reason, or there's something else happening as to why you're not doing something that you know is actually in your best interest? And my guess, most of you are shaking your head, yeah. So that's sort of the core underpinning philosophy of MI, is that when we face change, no matter what the change is, the first thing that happens is we're ambivalent about it. It's not that we don't want to change. It's not that we're in denial about the change. It's not that we're not even aware that we should be making this change. The truth is we face change with this sense of ambivalence. And I love this picture because it's a great, it's just a great quick illustration of what ambivalence feels like and what it's like. So if I use diet as an example, because I'm almost always on a diet and always wanting to be losing weight, on the one hand, so if I look at the angel side or the change side, there's lots of reasons why I want to change. I feel better when I'm lighter. I have more energy when I'm lighter. I can go on hikes more when I'm lighter. I can be more active with my kids when I'm lighter. I like how my clothes feel when I'm lighter, and I don't want to get diabetes. My mom has diabetes. And on the other side, when I look at the little devil side or the don't change side, at the same moment, in the same breath, I can say I also don't want to change. I really enjoy food. I like being able to eat whatever I want. I like going out. You know, part of my social life is going to dinner and enjoying company and having good meals. I don't really love exercising. I like hiking, but I don't like going to the gym. I don't like getting sweaty. So on the one hand, I do want to change because I just said all those reasons, my health, my feeling better, and I just like how I look overall. And on the other side, I just don't like what it takes to change. I really don't want to do it. So both of those things underline, there are these three questions we're asking ourselves all the time. Is, should I change? Which means, is this important enough for me to change? Does this outweigh the benefits of not changing? And can I change? This is that self-efficacy piece, again, that we talked about with the FRAMES program, or FRAMES framework. Can I? Do I believe I can? So if I did decide to do this thing, whatever it is, lose weight, do I actually believe I can do it? Do I have enough self-efficacy or enough confidence to believe I can make this change? And then the third question is, will I? Is this the right time? Like, will I actually commit? Is this something for now or something for later? So when we hear our clients, we want to be thinking first is like, not, are they for or against change? We want to understand what is their view of change and what's the ambivalence about. So on the one hand, in the example we just talked about, the dad does want to protect his daughter on the side of change. And on the other hand, he doesn't want to do it today because he promised her that there were no shots. So he's ambivalent at the moment about getting the shot because on the one hand, he made a promise to his daughter, and on the other hand, he knows that he wants his daughter not to get sick. So we want to think about what is the ambivalence here as the first place to start, so we can really meet our patients and our patients' parents at a place of empathy and understanding. All right, we can go to the next slide. Because what we know is that people change when they're ready, willing, and able. So when it's important enough, so when the cost benefits of this change outweigh the cost benefits of staying the same. And oftentimes we can help increase the importance of a change by attaching it to someone's values, what's important to them, and how does this change support what's most important to them. That's the willing part. The able part is this confidence piece, the self-efficacy. So do they believe that change is possible? And it's not have they done it before, but do they actually believe they can do it? And the thing about self-efficacy is it can be both specific and global. So global meaning I can be pretty confident in my life in general. I can accomplish most things. If I put my mind to it, I can solve a problem. But then specific around one behavior change or one target, I can have low self-efficacy. So for me, as an example, in life, I do fairly okay with goals that I put out for myself, career-wise, family-wise. But when it comes to weight loss, I have lower self-efficacy. I've had up and down weight loss, successes and challenges pretty much since I was 12. So when we think about self-efficacy, we want to think about how does this person feel that they believe is possible for themselves around the target that we're talking about. So in this situation, we're talking about feeling confident that they can get HPV vaccinations or that it's the right thing that they want to do. And then the last part of being ready is commitment. So are they actually ready to do it right now? Because oftentimes people might be thinking about it, might be important to them, they might believe they can, but maybe it's not right now. Maybe it's I need to wait till after the 4th of July or after the holidays or something. So is the change a priority at this moment? What's the urgency behind it? So that's big picture, sort of the concept behind MI. And you can scroll up. So what we also want to know is that there's a difference between a target behavior and a target decision. So most of the time MI is around behavior change. So helping someone decide whether or not they want to lose weight, whether they want to exercise more, whether they want to follow a medication regimen, whether they want to come consistently to care. That's like a behavior. But there's also a frame of a target decision. And what that means is, MI traditionally is used to help someone decide whether or not they want to change something like substances, weight loss, flossing their teeth. But the definition in the new MI book, the MI3 version, helped us sort of expand it to helping someone make a decision as well. Because when we're making a decision, first we need to be sure that as a provider that we can actually ethically help guide someone towards a decision. Or do we need to stay in what we call equipoise, which is actually an equal position and not weighing in on the pros and cons of a decision? Or we use a skill called decisional balance. So an example is if a patient was coming in and trying to decide whether they should buy a new house or if they should have a baby. Those aren't things that we would have an ethical stance on. That's completely up to them. Unless there was some medical reason having a baby might be challenging for the person. Having a baby is completely their choice. But in the case of HPV vaccination, there is an implied benefit to the patient, the same way that we can guide someone towards whether they want to change their use with substances like meth or cocaine or other substances. There's an implied benefit, so we can guide the person towards the pro-social or pro-health decision. And so with HPV, we can also guide them because there's an implied benefit to the person. And what MI can do is can help them decide. And the communication style we use is really just this idea of guiding. I love this image. It's like sort of going together through this little river, through this valley. And the idea we want to have underneath our clinical approach is I can help you to solve this for yourself. So they're the one that's going to make the choice. They're the one that's going to make a decision. And we're just there to help them guide them through the process. And what comes up for us as providers is this instinct that we have, and it's called the writing reflex. And what it refers to is this urge or tendency to try to actively fix someone else's problem. The good news is it comes from good intentions. It usually shows up as advice, education, persuasion, confrontation, with the goal of helping the person or getting the person or the client to see the reality of the situation so that they will be ready to change. And this usually what it will do is actually predict that the client is going to argue against change. And oftentimes we might label this as denial or resistance. So if you go back to the picture we were talking about a minute ago, if we take the side of the devil and we are arguing for the change, we're saying all the reasons this person should change, the only thing that's left for the client is for them to take up the opposite argument. So if you think about it like two lawyers in their head arguing for this change, and we're arguing all the reasons they should change, the only response that they have to make sure that we understand the full picture in their head is to argue against change. So what we don't want to do is lean into our writing reflex. So when we feel like we want to tell someone what they should do, or we want to pressure someone into change, or we want to convince them, or even if we go back to our example of, if somebody lectured to me about all the reasons why I should be flossing my teeth, it's not going to actually produce change. It's just going to make me resistant and not want to talk to my provider. But the thing is, we have this instinct because we're kind, caring people and we want to help. So it will come up. We will feel like it's helpful. I should tell them what to do. What we know, though, is that doesn't actually lead to change most of the time. Occasionally it might. There are certainly small situations where it does make a change, but in the majority of time it doesn't. And I love this quote from Blaise Pascal: people are generally better persuaded by the reasons which they have themselves discovered than by those which they have come to the mind of others. And that's really what we want to think about, is clients don't want us to be the experts telling them how to live their lives. we do want to guide them towards what is medically appropriate and what we think what science says, but then they get to make their choice, and we don't want to pressure people into making choices that are not right for them. So that brings us to the spirit of MI. And what we know is all the skills of MI have to be grounded into this, what I would call heart set mindset. Actually, go back to the picture, Jamie, thanks. Heart set mindset of a client. And I love this picture of David. When they asked Michelangelo, how did you create David? His answer was, I didn't create David. David was already in the marble, I just brought him out. And that's really what we want to think about with clients, is clients have their own reasons to change. They have their own ideas, their own solutions, their own ways of approaching things. And our job is just to bring it to the surface. So the same way with Michelangelo trying to get this beautiful statue out of a big slab of marble, our job is to use our skill and our empathy and our process to help bring forward what already is there in the client, their own reasons to change, their own ideas, their own suggestions, their own solutions. And that's what MI helps us do. It helps us really understand the client's ambivalence and bring forward what's most important to them. So there's lots of definitions of MI. These are probably the two most relevant. So for layperson, MI is a collaborative conversation that is style for strengthening a person's own motivation and commitment to change. For practitioners, a little bit more detailed, MI is a person-centered counseling style for addressing the common problem of ambivalence about change. So it's really this idea of staying person-centered so that we can help resolve that uncomfortable feeling of being stuck in that picture we saw earlier. And the spirit of MI has four main components to it: collaboration, compassion, evocation, and acceptance. So let's break those apart, because what we do know is we can train on the MI skills, but if the spirit isn't there, we will not get the same effect that we see in the research about of all the impact MI can have in helping someone change. So with collaboration, what that means is MI is a person-centered partnership. So that means it's a give and take. I, as a provider, am going to guide the conversation, but the client gets to help set the pace and the tone and what we talk about specifically. So it's a very collaborative back and forth. Not one person's in charge, not one person's the expert. We're both equal experts. The idea of MI is done with someone and for someone rather than onto and not to do or be done to someone. The other piece of spirit is acceptance, which is the idea of absolute worth. We accept the client for their worldview. We trust that they are making the best choices for themselves and their lives, and we just accept where they are. That doesn't mean we stay where they are. We are going to guide a conversation so that they can make health choices that might be better for them, but we do want to accept their view of things. We want to use accurate empathy, which means using reflections to accurately express back what we think the person feels and means. So what we're making guesses at what they're sharing with us and why that might be important to them. We want to support autonomy, which you saw with frames as well. We want to say like, this is their choice and control. They have choice and control here. They get to decide. It is up to them to decide what's best for them and to make choices around their own behavior. And we want to affirm people to really build that strength. So when we want to notice a value or strength, we want to affirm them. We also want to think about compassion, and compassion is different than empathy. Empathy is understanding their situation and trying to reflect what that might feel and mean. Compassion is its deliberate commitment to actively promote the other person's welfare and to give priority to the other person's needs. So the whole conversation should be around what's best for the person in front of me, not what do I think is best or what's best for my practice or whatever might else be a competing agenda. And then evocation is both a skill and a process in MI. As part of the spirit part, what it is, it's a belief that the patient should be the one arguing for change. I should not be the one arguing for change. And that I believe that I want to evoke this and strengthen what's already present in the patient, not instill what's missing. So they don't need me to teach them something, to be an expert, to tell them how to think. I just want to pull forward what's already there. And just a little bit more detail on accurate empathy, because it also is a skill in MI. It's this ability to show active interest in understanding the other person's frame and perspective, and to use the skill of skillful reflective listening to be able to do that. So it's a fundamental skill we want to get better and better at as we learn MI. And the goal is really to understand what the speaker is experiencing in his, her, or their situation, not just what they're saying, but what does this mean? How do they feel? And that shows up in a skill called reflective listening or reflections. And what that does is it invites dialogue. It can reflect the content, but we also want to be able to show we're reflecting the feeling and the meaning. It also can reflect what is not being said, so the things that are underlying there. We are going to make a guess, a hunch, a hypothesis, so we're reflecting meaning, what we think this means. And it also can help clarify assumptions. If we're not quite sure what a client is saying, we can say, so I think what you mean is X, and that'll help us get there too. So the MI spirit, really the way, if we're doing it well, it feels like we're dancing with our clients versus struggling and fighting with them around something. And that's sort of the intention we're trying to get to. So with MI, there's really three main core concepts. There's the spirit, which we just talked about. There's also the processes, which is how you guide a conversation. And then there's the skills. And so with the processes, what they are both linear and recursive. So you can see on this picture, there's 4 processes in MI. Then this comes from the new version of MI. So if you were trained in MI years ago, this might sound new to you. But the first one is engaging. And what engaging means is our first job when we meet with a client, and where we start and always start, is to understand them and specifically understand their ambivalence. And that's that builds trust and respect, and it's via acceptance and compassion. So we want to accept their view, we want to understand their view, and we understand how they feel 2 ways about the thing we're talking about. And then we want to pick a specific focus. Sometimes our focus is very obvious because there's a target behavior we've already started talking about, like smoking cessation. In this situation with HBV, it's clear from the beginning. We're going to invite the conversation around HBV, so we don't have to do a lot of work around focusing. But sometimes with MI, once you're understanding ambivalence, the focus might change. It might be a different behavior or a different decision that we're focused on. And then the process of evoking is next. So that's the idea of drawing out the client's own reasons to change, why this is important to them, what they think is possible, and whether they're ready and willing to do that. And we want to bring that forward. And then when we hear readiness or commitment, then we move into planning. And planning is seeking and eliciting that commitment, but also breaking down into steps. And so we want to think about these 4 processes in order, so we cannot evoke if we haven't focused or engaged, and we cannot plan if we haven't evoked, but they're also recursive. We might go to the planning stage and we can hear ambivalence again, and we might need to go back to evoking. So they build on each other, but they also kind of go up and down like a stair step. And what we're listening for is this idea of MI, so what is the goal? What's the point of MI? What we do know is that MI doesn't equal change. If we do MI, we can't guarantee a client is going to choose to change. What we do know, though, is, next slide, please, is what MI does is it actually is, sorry, you can keep going. Next slide. What MI does is it predicts change talk. And change talk is, in research, is part of the conversation and the client language that we can link actually to client making choice to change and link to client outcomes. And so what MI does is it grows change talk. And we use this acronym DARN, desire, ability, language that leads in the direction of change. So I want to do this thing. I believe I can do this thing. This is the reason I should do this thing. If I do this thing, this good thing will happen. If I don't do this thing, this bad thing will happen. And I need to do this change. If I don't, I'll have a heart attack. If I don't, they'll take my children. So we want to be hearing and listening for and evoking the specific language in the conversation and around the language towards change. And when that happens, next slide, when we hear this darn talk, that leads to commitment language. And commitment language is when we know someone is actually ready to change. So when we are just hearing the darn talk, that means someone is interested in changing and are thinking about it. And when we hear commitment, that tells us that someone is ready to change. And what we know with commitment is that leads to, the next slide, please. That leads to people taking actual steps, actually getting involved, starting to change, putting the steps in place to change. And when that happens, then the next slide is where we know that we actually do see change. So what we want to know about MI is the process to get to change. It helps us grow the change talk, which leads to commitment language, which leads to taking steps, which ultimately leads to change. And so what is change talk a little bit more? And we call this darn cats because there's preparatory change talk and then there's readiness or activation change talk. And so what we want to be listening for in the conversation is, what does the client want in the direction of change? What do they wish in the direction of change? That's our D, or a desire. We also want to be listening for what they think is possible, which is our ability language. What do they think they can do or could do or have done in the past? And then we want to listen for reasons. So why is this even important to them? Why should they even consider it? Here's just some examples for their kids, for their health. And then what about the urgency? Why do they need to do it now? What's happening around that realm? So we want to be listening for both the importance language, which is that desire, I want to, reasons, I should, need, I have to, and then also our confidence language, which is our ability language, I think I can. And when we hear lots of preparatory change talk, especially if we hear it in those categories of importance and confidence, I want to and I can, then we'll start hearing activation change talk, which is commitment language. I'm going to, I will, I intend to, I plan to, or actions, taking steps. I am, I did. And so we want to be listening for this specific language when we're talking with clients, because this is the language that leads to change. And so MI is really an attention to language. We want to know what we're hearing when clients are talking. And we likely are going to hear three sort of categories of language. We're going to hear change talk, which is which we want to seek, listen, invoke, and grow and grow and grow. And we are going to hear sustain talk. And sustain talk is basically all of those acronyms we just talked about, the darn cat, but in the opposite direction. They're in the direction of staying the same. I don't want to lose weight. I don't think I can do it. I really enjoy nachos. I don't really have urgency. My health is fine. I don't need to do it now. That's sustain talk. And we want to soften that. We don't want to grow and understand that side of ambivalence any more than what is present. And we might also hear discord, which is around just there's something in the relationship between me and my client that feels pressured or tense. And that's triggers for us to repair the relationship or do something a little different. So we really might hear these three different sort of categories of conversation or category of language from our clients. And I love this quote: if you're arguing for change and the client is arguing against it, you're going exactly backward. And that's this point of discord. So if we feel that tension in the relationship, then we want to shift to understanding the client perspective and try to grow the change talk and possibly repair the relationship if we're hearing anything in the category of discord or pressure in the relationship. Next slide. So how do we recognize discord? It usually shows up like this. Clients arguing, they're challenging or being hostile, they might be ignoring us or having inattention, there may be no answer or no response, or sidetracking, changing the topic. They might be interrupting us, talking over or cutting us off, or negating what we're talking about, blaming, excusing, claiming impunity, minimizing, denying, or pseudo-complying, which is that blanket agreement or passivity. So these are just common ways that you might see discord, which are a time to just check in on the relationship and see how we're doing. All right, let's talk about the Epe model, because one thing with HPV vaccinations is we do want to provide information if the client doesn't have accurate information, or if the client is just unaware of what HPV is or why it's important. And MI gives us a style of how to provide information called EPE. So first of all, why do we do that? Why do we want to have an approach to providing information that's MI consistent? Because first, we want to support client autonomy. You saw that with frames. We want to always support client autonomy. We want to do it again here with MI. Because if we push, the client pushes back. That's that writing reflex we were talking about. It's normal for the client to push back. Remember, there's two lawyers in their head. If we take one side, they have to be the other lawyer. We also want to understand first what the client already knows. There's no point in us educating them on something they already know. That just feels like us, being lecturers, or what I refer to as Charlie Brown's teacher, wah, 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 wah. They've already heard all of this. So we want to first understand what they already know, and to also be able to correct any misunderstanding if there's something that they might be misunderstood about. And we want to know what the client already believes about HPV, because again, we don't want to come at them pressuring or challenging them. We want to understand their perspective and then fill in any gaps in knowledge or information that might be helpful, because we do not want to argue with people's beliefs. We want to make sure they have factual information. And we also want to reflect their own reasons for change, why they're even considering possibly vaccination, to grow that change talk and to help guide them towards making a choice that is best for them. And just keeping in mind, we want the client always being the one arguing for change rather than us taking up that lawyer voice in their head. All right, we can go to the next one. Next slide. So here's what it might sound like as a flow. As an example, would it be okay if we talked about HPV vaccinations for a minute and we wait? What do you already know about HPV? And then we want to reflect and affirm whatever the client is saying that is true or accurate. Or you have already done a lot of research on this, you've already thought about this, and this decision is important to you, or whatever else they might share. Then we want to ask permission. This is the P part, and permission to provide. Would it be okay with you if I told you a little bit about the most recent medical recommendations regarding HPV? The decision to get vaccinated will always be yours to make. And then we would share whatever relevant information we think is important for them to know, especially if there were gaps in their knowledge from above when we asked what did they already know. But we also want to sort of think, what's your biggest bang for your buck here? We don't want to just list an entire research article. We want to highlight what's most important that we want the client to pay attention to. And is there something specific that we're wanting to draw their attention to? And again, we do not argue with something that they said that we disagree with, like their belief in vaccinations. And then lastly, we want to elicit, what do they think about that with information we just shared? How does that change how they might think about vaccinations, if at all? So again, elicit first, what do they already know? Permission, would be okay if I share some thoughts, narrowly share and to fill in the gaps, and then elicit again, what do they think about what we just shared? So here's how an HPV conversation might go. We want to start with partnership language. Would it be okay if we talked about this for a few minutes? Ask permission to talk about it, affirm what is important to them, reflect what we hear them saying, both simple and complex, meaning making sure we hear them, but also making those guesses at what they might feel or mean. Then we might do elicit provide around information around HPV. And then back, we want to have empathy and empower them to make a choice, emphasize autonomy, and then evoke reasons, needs, and desires around the possibility of getting an HPV vaccination, and then guide them towards making a choice of what they think is best for their family. So let me play another demonstration for you. This is an MI version of what of the same conversation.
So would it be okay if we talked for a few minutes about the HPV vaccination?
So I told my daughter that we're not going to do any shots today, so I don't think we'll do it this time.
Yeah, so it's really important to you to honor what you've told your daughter.
Yes.
Yeah. And we certainly don't have to do anything today, but would it be okay if we talk just about the HPV for a few minutes?
Suppose, yeah.
Okay. So what do you already know about HPV vaccinations?
I know it's to prevent sexually transmitted diseases, and I suppose I think my daughter's a little young. She's only like 12, and so I don't think she really needs a vaccine for sexually transmitted diseases right now.
Okay, so you know that it's sort of related to sexual activity, and you're wondering about whether she needs it now because she's so young, and how that sort of fits in with what you've already told her about no shots today too.
Yeah.
Okay. Yeah. If it's okay, can I tell you a little bit, provide a little more information about HPV?
Sure.
So what the CDC actually recommends is that HPV should be given before kids are sexually active. So that's why we actually target 11 to 12. And since your daughter's in that range right now, that's where we want to start thinking about getting HPV so that she doesn't end up having HPV related diseases, you know, like cancer and other things that can come from HPV. So I'm wondering what you think about that.
Well, I certainly want to protect her from all of that, but I did promise her today, and I guess I'm still a little confused why we can't wait, because I assume, you know, she probably won't be doing that kind of stuff till later, I don't imagine.
Yeah, so it's really important you to honor what you've already said to your daughter, no shots today. And it's also really important to you to make sure she doesn't get HPV related illnesses. That's important to you. And you're just sort of wondering right now, like, where do I go with timing? Like, does it have to be today, or is it something that maybe could happen later?
Yeah, that's, I suppose, if we could do it later so I can keep the promise I kept to her and not have to make her get a shot today.
Yeah, and that's absolutely, obviously your choice and something that absolutely I would support. And yeah, we can do it later. So what thoughts do you have about that? When would feel like a time that that might work for you and your daughter?
Well, when do you and the CDC recommend that we get it by?
Yeah, so there is a 2-shot doses that we want to do before she's 15, and then there's a 3rd doses after she's 15. So really, it's up to you. So if I'm hearing it's pretty important to you not to do it today, since you promised her no shots today, and that you want her to respect what you say and trust what you say, and that's really important to you. And also that you want to make sure she gets the shot in time. So there's lots of options. We could do it in 6 months. We could do it in our next annual physical. We could come back in a week. What feels right to you guys?
I suppose we could do it in 6 months, make sure she's protected from all of that, but also to not have to do it today when I promised her I would.
Okay, yeah, that sounds perfectly fine. So why don't we go ahead and get you scheduled and to come back in 6 months? I'll take you guys up to the front. You can make an appointment to do that when you guys come back.
Sounds good.
Okay, great. So you can see there's similarities to the frame and the MI conversation. They're slightly different. They both are emphasized some of the same things: autonomy, empathy, and providing information. They're just done in slightly different ways. So why don't we stop there and see if there's any questions from any of you. Feel free to write in the chat, or there's a question thing on your right. You can write any questions that you might have. Okay, looks like we don't have any questions, so that's great. Well, just want to thank you all for coming. I really appreciate your time. Thank you, Jamie, for having me.
There looks like there might be one question that just popped up from Christine. Says, would it be appropriate to loop the kids into the conversation as well?
Yeah, it absolutely depends on the family. If I were doing it, I would have the kid in the room while we were talking together with mom and dad, or whoever brought the child, the caregiver, just because I think the child might have their own perspective. It gets a little more complicated because you're going to need to then listen to the frame of each person. So what's important to parent, what's important to child, and how do you come to a collaborative decision there, but absolutely, because we're talking about the child, and the child's the one getting the shots, but it also, I think, depends a lot on the relationship you have with the parent and the caregiver and how they view that, but absolutely would be fine to have the child in the room too. Any other questions? Great. Well, thanks again, Jamie, for having me. Hopefully this was helpful. If anyone wants to reach out, I think, Jamie, do I have my contact on the last slide, I think?
Yep, and I'm also going to be doing a couple of housekeeping slides when we're done as well, just for everybody to make sure that they're able to print their certificates from EADS as well.
Okay, great. Go right ahead. And you can just go to the slide of questions, and thank you.
Okay. Okay, everybody. So I am going to go skip through a little bit here. Okay. So if anybody does have any questions about the webinar today, please feel free to reach out to me at jmontgomery@semhealth.org. The recording is going to be posted on the opec.org/webinars-1 website. And moving forward, your activity code, this is going to be really important. It does expire after 7 days. So if you could please write down this activity code, you're going to log into eeds.com. That's www.eeds.com. You're going to use this activity code to actually print your certificates. If you have any trouble at all whatsoever, please reach out to me. Also, there is a email address in the bottom right hand corner for Cindy Koch. That is also another person who is a good point of contact should you need some assistance with getting your certificates printed. And I'm going to move on just a little bit here. Again, here is the code. Again, that does expire in 7 days, so it is extremely important that you guys do go in and get your certificates printed immediately for CME or CA credits. And we just wanted to make sure that, again, if you guys had any questions, if you had any additional comments, you can go ahead and send them to me. I'll make sure that they do get forwarded on to Colleen Marshall so that those can be answered. Usually we get a turnaround time response for those within 24 to 48 hours. All right, so again, thank you so much for joining us for the webinar today. We hope you have a wonderful day, and don't forget to print your certificates.
Bye, everyone. Thank you.